Afternoon, dear colleagues and doctors. We always wish to start on time, though we are 10 minutes late, but let other people join in the meantime. That's not a problem. And I give you a warm welcome to this CME, and it gives me an immense pleasure on behalf of Prime Academic Society to welcome you to Echo Chandigarh 2025, a gathering which brings some of the finest minds in echocardiography, cardiology, and imaging. Echo Chandigarh always had been more than a conference. It had been a celebration of learning, collaboration, and pursuit of excellence. Each year, we strive to create a platform where science meets experience and where discussion leads to further understanding and which would lead to a better patient care. This year program reflects the core philosophy of Prime Academic Society to advance academic exchange, promote quality education, and foster friendship amongst professionals who share a common passion for improving cardiovascular care. We are privileged to have with us the outstanding faculty, the who's who of echocardiography in India, and they traveled all across the country and kept their busy schedules for us to share their experience with all of you. It's my heartfelt thanks and appreciation to the delegates who have traveled across India, right from East India and from Karnataka. We had a workshop in the morning at Sector 24 today. Uh, we, I acknowledge the effort of the Prime team who had been instrumental in making this conference to give its shape. And one of the person is standing right here. And that team has helped me relax, and these guys have taken over to do a good job. I wish you now an encouraging, enlightening, and enjoyable Echo Chandigarh is 2 days conference, and let this Echo Chandigarh, through excellent talks, the delegate interactions, be the best eco conference in this region. Thank you very much, and I welcome you all to this August gathering. Now, we would start the first presentation, and that would be by me. And I invite the chairpersons because this is an afternoon. Most of our cardiology colleagues are busy and are not been able to keep up to this time, but that's all right. We have Dr. Ajay Behal, Professor of Cardiology from PGI. He is an intervention cardiologist, but more than that, his area of interest is cardiovascular genetics, be it is cardiomyopathy, but he's done an extensive work in hypertrophic cardiomyopathy, and I end up sending all my patients of hypertrophic cardiomyopathy to him for the further genetic and other workup, where he actually excels in this field. Next, I request my close friend, Dr. Ajay Jindal from Roped. We've been associated for at least 3 or 4 decades. He's doing echocardiography at Roped at his own diagnostic center. Welcome, Dr. Yeah. I request Dr. Tarandeep Singh to please join the podium. He is doing an echocardiography in the Tri-City. He's changed the scene of echocardiography. He's a pediatric cardiologist, take care of pediatric cardiology work. And he is associated with number of hospitals, does a good job of doing fetal echoes as well as pediatric echocardiography. So it's my privilege to introduce myself, because I'm the moderator, I'm the speaker. So Dr. UP Singh did his MD and MBBS at Amritsar Medical College, did DM cardiology at PGI in 1993, and ever since that dedicated to a field of non-invasive cardiology for more than 3 decades. As I was the first person to begin, so I pioneered many of the echocardiographic techniques in this region. So I'll save time as we are about 10 to 15 minutes behind the schedule. So I'll start with my talk on dilated cardiomyopathy and would be very brief in that and save at least 10 minutes at the end so that we finish on schedule. Okay. So dilated cardiomyopathy, guys, you stretched it. You stretched it. That's not okay. That's seriously. I'll continue, but you've stretched it. The ratio is gone back. It's not. You're not maintaining the ratio. Okay. With what do you want? So should I go to? No, 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 don't change the ratio here. No, wait for a minute. Wait for a minute. Let me try something else. Give me 1 minute. Okay. So now let me try this. Let me do this. Okay. Give me 1 minute. Okay. Again, we have the same issue. Well, okay. It won't affect.
I need to change the ratio of the
No.
it is coming.
Let it continue like this.
I'll just check.
You can check later and you try to do it there. Mr. Tarun, who is managing this AV, is a close friend, so I cannot scold him, obviously, here. I'll do that later. Okay. So now, dilated cardiomyopathy is a myocardial disorder with LV dilatation and reduced ejection fraction. And in absence of causes which can do it, which is coronary artery disease, hypertension, valvular heart disease. So it's got to be an idiopathic uh, cardiomyopathy. But what if we have a myocardial dysfunction with no other cause and LV is not dilated? How can we call it dilated cardiomyopathy? No, we can't. There is a separate terminology, hypokinetic non-dilated cardiomyopathy, and that is HNDC. So there are various causes of cardiomyopathy apart from those structural defects which are not present. Then there are genetic disorders which can do it. Myocarditis again is the common reason to have a cardiomyopathy later. You have a lot of autoimmune systems like SLE, rheumatoid arthritis, and many more to create LV dysfunction. You have various toxins which can do it, and the commonest one is alcohol. Then you have many drugs, and now we are using chemotherapeutic agents, and the cardio-oncology is a special field in itself these days, can cause a cardiomyopathy. And there are endocrine causes of cardiomyopathy. Diabetes is one of them. Remember that it's pretty common to have a cardiac involvement in diabetes without involving coronary arteries. Peripartum cardiomyopathy is another subset of patients which produces. And then cardiomyopathy is a very vast topic. I'll just pick up small patches in between so that the areas which you may not be very comfortable, I'm going to answer that. What if you have dilated heart with the left ventricle hypertrophy? Okay, so then these are the possibilities. It could be hypertrophic cardiomyopathy, burnt out, very rare. But most common is a truncated hypertension. You have hypertension, the guy comes to you with the heart failure, the blood pressure is less than 100, because LV is unable to generate the pressure. The moment you start treating that heart failure, ejection fraction improves. That is the time, many a time, you realize that patient has hypertension, blood pressure goes on the higher side, even if you continue to use ARNI or ACE inhibitor, antihypertensive. More ARNI and ACE inhibitor you use, more the blood pressure rises. It's absolutely a paradox. Sarcoid and other inflammatory disorders can do it. Amyloid myocarditis, which I've already discussed, where you can have hypertrophy. Dilated cardiomyopathy is a peripartum cardiomyopathy, which you can have an association, which is probably gets unmasked in loading conditions of pregnancy, and you already have a genetic preset or a genomic defect, which can cause LV dilatation. Use of chemotherapy or radiotherapy during the childhood, and those patients become pregnant later, is another subset where you can have a peripartum cardiomyopathy. A good amount of alcohol per day is required for at least 5 years to produce dilated cardiomyopathy of ethanol use. And I know all of you must be using less than that. Anyway, the malignant ventricular arrhythmia is pretty common, and so is a requirement of ISD, ICD in this category of patients. And thiamine deficiency is quite common in alcohol, so you supplement that to improve ejection fraction. The peripartum cardiomyopathy, again, you can use a bromocriptine, which has been shown in random trials to be some benefit if you use it for 6 months. One can have cardiomyopathy related with the tachycardias in even the multiple ectopics. Ventricular ectopics can do it, and we're not sure whether hen comes first or egg comes first, because all those cardiomyopathies also can lead to ventricular arrhythmia. So we don't know which is happening first, and many a times if you treat tachycardia, those malignant ventricular ectopics, the cardiomyopathy tends to improve. So metabolic conditions can cause, skipping that, I'm going to show you the mimics of cardiomyopathy. Now, in this patient, this is a young school teacher presented with dyspnea. There was no angina. And you can see there is an LV dilatation, some hypertrophy, and mild mitral regurgitation. Of your notice, you'd go to some calcification here in the endomyocardial area. That should be the clue to think of something else, conditions which can produce calcification in the subendocardium. Again, you have ejection fraction low, some regional valve motion abnormality. The posterolateral segment is slightly hypokinetic, LA is dilated, and the clue comes from here. You have a prominent right coronary artery which a markedly increased flow, and because this could be happening because of increased flow and some shunting somewhere in the bed of the right coronary artery. And we see the prominent descending PDA, we see the circumflex artery very prominent, and then we see the left coronary artery actually draining into pulmonary artery. We say Al Kappa, the left pulmonary artery originating from the pulmonary artery, true, but actually it drains into left pulmonary artery because PA pressure are lower than the systemic pressure. So this was the patient of Al Kappa. Understandably, treatment, prognosis, outcome are all different. A child with a dilated cardiomyopathy, LV is bad. There's some trabeculation. LA is enlarged, fossa bulging. There is a moderate to severe mitral regurgitation. And then you do a suprasternal view. Then you see there is some aliasing here. And then on this is a view of descending aorta, and you can see the continuous flow. So this was the dissection, the coarctation of aorta causing dilated cardiomyopathy. Another young child with the LV not very comfortable, not contracting well, but in fact this is not LV, this is RV, because this is the patient of congenitally corrected transposition, which actually eventually gives away to the systemic pressure. So this is the right ventricle. And how do I say that? The tricuspid valve, which goes with the ventricle, is towards the apex rather than base. So this is left ventricle, this is right ventricle, coarsely trabeculated and a moderator band. We have a young patient again, heart failure. Father also died of heart failure. So we're talking of some genetic association with cardiomyopathy. And you see this non-compaction of LV. And this is a non-compaction at the LV apex, which is very marked. You know, there are a number of criteria to make a diagnosis of non-compaction. And non-compaction can, you can see these recesses where blood can actually go in and out. And here you have to reduce the Nyquist limit, increase the smoothness. The tricks which I told you in the workshop today, if you want to see recesses filling with the blood. And that's what happens. The LV does not compact well. There is a large area of a non-compacting myocardium, which is same size of the compacting myocardium, to call it as a dilated cardiomyopathy. So once you have a dilated cardiomyopathy, you're obviously interested, am I missing some treatable cause like coarctation of aorta? It's a good idea to have this checklist in cardiomyopathy to find out. And then is my treatment appropriate? Are there echo-based treatment variations? Is there a chance of recovery of ejection fraction? Is my patient a high risk category in dilated cardiomyopathy? So let's answer that first. Is my patient high risk category? So we know and number of phenotypes of cardiomyopathy with the ejection fraction varying from 20 to 40%, but many a times 40% ejection fraction patient have more symptoms than the guy who has 20%, and the mortality also is very variable. You cannot base mortality only on ejection fraction, and it's a good idea to kind of figure out the high risk patients in dilated cardiomyopathy. What could be that? There are markers on echocardiography which can help us make the diagnosis and assess a high risk. One of them is a GLS, over and above ejection fraction, any thrombus which is obvious, functional mitral regurgitation. Whenever we have a talk on dilated cardiomyopathy, we actually forget this some important entity, which is functional mitral regurgitation, where mitral valve clip can be of some help. LA functions again is very, very important. RV functions. So LA and RV functions are critically important in symptoms and prognosis of heart failure with the reduced ejection fraction. I'll show you a couple of slides in favor of that. And cardiac MR, and as I told you in the morning, cardiac MR is getting gold standard in almost all diseases of cardiovascular system. GLS, we know even if the same tertile of ejection fraction, if you have a GLS which is low, the survival is poorer. Same if the GLS cutoff, which is minus 9.4 in heart failure with reduced ejection fraction, you have a very divergent graphs indicating higher mortality, morbidity, and hospitalization. Functional MR, when LV dilates, pulls the papillary muscle and goes kind of defaced, and cordia tense, the whole apparatus goes bad, and that causes mitral regurgitation. And then you can use a mitral valve clip in these kind of conditions to correct. There are two trials which were done, and you have to make an assessment. ILV dilatation should be out of proportion to mitral regurgitation. If you have poor ejection fraction and regurgitation, it's a prognosis and outcome with the clip is better. I would not go into those details. And I'm going to tell you about left atrium. So we discussed in the morning the left atrium volume index is very, very important marker of a prognosis in heart failure. There have been a meta-analysis which showed that if you have a triple vessel disease, ejection fraction, and other parameters, then if you put an LA volume hazard ratio is about 7.5 to 8 as compared to ejection fraction hazard ratio of about 3. So LA volume is a better prognosticator than a triple vessel disease, than an LV ejection fraction. Let's start looking at LA volumes. It's very important. If you have a clinical data, all-cause mortality, you add ejection fraction, you add diastolic function, and you add LA, there's an incremental value of mortality and morbidity with LA volume plane. LA volume is HbA1c of diastolic functions. So now next feature is the right ventricle functions. You have this right ventricle on this side, which is not good. Please, and when you are assessing the right ventricle functions, do not have a visual impression of the right ventricle function. The reason, if you have an LV which is bad, the RV, it is less bad, but it might look normal as compared to LV which is really bad, right? So many a times the visual impression is that LV is all right. Many of you still might feel that RV is contracting reasonably okay, but it's not. Okay, so do not, our visual impression goes bad in case LV is also dilated, and this is good right ventricle function, non-dilated right ventricle. Right ventricle assessment in with the TEFC less than 15, more than 15 in dilated cardiomyopathy. Look at the cumulative. Uh, if you have ejection fraction of 20, 40, look at the difference of all-cause mortality. It almost doubles if the right ventricular ejection fraction is less in heart failure with reduced ejection fraction. Cardiac MRI. This is an independent predictor. LGE is an independent predictor of mortality, arrhythmia, sudden cardiac arrest in patients with heart failure. And secondly, we can also pick up other causes for when you're doing a cardiac MR, you can pick up infiltrative disorders by accident or by choice in dilated cardiomyopathy. Showing you a case, she's 56 years female, and look at the LV which is bad. You see some rocking movement at the LV apex, see some jerky movement, maybe an LBB she had, and then, so this is dilated cardiomyopathy and RV functions were not good. Agreed for so far? Okay, so now let's see. I'm going to take you to this. Now, LV, this is the normal LV contraction. There are various movements of LV. There is a squeezing movement of base and apex, which contributes to about 20 to 30% of the ejection fraction, which is quite a bit, right? So if that contributes, let's presume there is, how do we know that there is a torsion? This is the normal patient. There you see the rotating movement, apex and the base, and then you see which side the apex and base are moving. One is moving on, apex is rotating on this direction, base is rotating on this direction. That means they are producing a squeeze. Both are moving in different directions, correct? So now in that patient which I showed you, this is the patient's radial strains. Look at the strains at the apex, and then both are moving on one direction. Okay, you know what does it mean? There's no squeezing, there's movement like this of the LV, correct? So this is what we call as a rigid body movement, and rigid body movement, when base and apex are moving on the same side, has a bad prognostic sign because it indicates there is a fibrosis right in the middle of the LV, which is preventing this rotation. And this rotation again is pretty common in patients with the non-compaction. Many patients of heart failure do improve ejection fraction, and that's the percentage of people improving in their ejection fraction. Recovery is pretty common and quick in Takotsubo cardiomyopathy, peripartum myocarditis, alcohol cardiomyopathy, selenium deficiency cardiomyopathy. These are the cardiomyopathies those respond very well. Tachycardia induced particularly atrial fibrillation with the fast ventricular rate. And you have noticed many a time you control atrial fibrillation, the heart rate and cardiomyopathy improves. So next is last bit of slides that when should I ask for a family screening? It's a good idea in all dilated cardiomyopathy to ask for the family history of sudden cardiac arrest, dilated cardiomyopathy, heart failure, because then you know there is a kind of a trait in the family which is doing it. And there are certain markers and points which can actually help you to guide. If you have low voltage graph, then there are certain genetic disorder which come into play. You have LBB and RBB, you have a short PR interval, or you have a prolonged PR interval that send you some signals. Okay, it's a good idea to do genetic workup in these kind of patients, and there are packages available for a dilated cardiomyopathy workup which cost about 25 to 30,000 rupees, if I am correct, Dr. Ajay Bahal, and which can actually help you uh, pinpoint is an whole exome sequencing which is available, and it's not a big cost to pay. So if you detect a genetic, what if I detect? Let's say in a index patient, in a ligand, if I detect diabetic cardiomyopathy and it's genetic, so I can do is I can screen the family member, not with ejection fraction, but with GLS. And if GLS falls like we give in oncocardiology, I might consider giving therapy like ACE inhibitor or beta blocker before, and provided I know that this patient or dilated cardiomyopathy have genetic disorder, and the same genetic disorder is in the sibling whom I am following and GLS has fallen, right? So that's what is an important, but we still less than 30% of the patients, even if the cardiomyopathy is genetic, we are unable to pinpoint the gene. Thank you very much. And I learned that I still have to learn a lot in life. Thank you. So I've saved about 13 minutes.
Thank you, sir, for the nice presentation. Sir, I have one query. Uh, Actually, like, for example, we are going to obviously screen the family members if obviously we are getting like genetic testing which is positive. So, what is the current status of medications? What are the guidelines? What do they suggest? For example, if somebody is having a like strain values which are not okay, so can we start these group of drugs in these patients?
I think I would open that question to the all faculty because I do not know the answer. The best person is sitting right next to you. You could have whispered in his ear, but let me share why I'm saying that. That oncocardiology, we thought that if you have a reduced GLS, you give ACE inhibitors and beta blockers, and GLS comes back, and you prevent the dilated cardiomyopathy to happen. Once the ejection fraction falls, if you start treating at that time, many a times it is progressive. But Tom Maverick recently done a very large study, a meta-analysis, which says that it doesn't really make a great difference. Still, we are back to the ejection fraction, not GLS guided heart failure prevention, or class A heart failure. That's what we call it, subclinical heart failure, right? So I do not have any answer. Given me a choice, I probably would start an ACE inhibitor or a beta blocker in this group of patients to prevent. Even in patients with the reduced GLS, where you have a reduction of more than 15% GLS, in a patient where I'm following up on my machine only regularly for a GLS in oncology, cardiology, this thing, the patient are on oncology unit. So if we want to see the GLS going down, even if ejection fraction is maintained, I think I would start ACE inhibitor and beta blocker. What is your opinion, Dr. Ajay?
I think there's an ongoing trial on this. So the
Okay.
recruitment is ongoing. And since the problem with all the uh, guidelines is they are evidence based. Since there's no evidence, there are no guidelines. So I think it has to be probably individualized. So right now, there's no evidence to show that if ECG, echo, MRI are normal and mutation carrier, giving a drug will prevent the disease. But that is based on no evidence.
And one very important, I think, lot of times we are seeing patients who have ejection fraction which is normal, but the LV is dilated, and we are obviously considering those patients also. I think it is a tricky thing in those patients also. Like, what further next, other than genetic testing?
I don't, I haven't seen maybe one or two patients in a long time dilated LV with no other reason and normal ejection fraction. You might call it LV remodeling to begin with, becomes globular, but that I've seen in the fetal heart. not in adult. I'm not sure. I've not seen too many patients with dilated heart. No other reason an ejection fraction is normal. Dr. JC, you would like to comment on that? Yeah. No. सबका मैं बैटरी चार्ज करूंगा आज शाम को। तैयार है ना? 440 वोल्ट से करूंगा शुरू। हाँ जी सर।
So the earlier part of the story was about mutation carriers. What should you do? And I agree with Dr. Behal. We just don't have any evidence. Actually, randomized data are missing, and they're not going to come that easy. And I tell you, even if they come, there will be a small study. There might be another study which will contradict the first. So it would be our intuition. Actually, I agree with you that I would start with beta blockers, ACE inhibitor, maybe even adjunct inhibitor. I come to the second part of the story. Normal ejection fraction. What is normal actually? Is it 51, 52, 55? What is normal actually? Basically, it all depends. If the normal value is 62 plus minus 7%, let's say, or 62 plus minus 5%, as the American study I could say, in that case, 52 in men and 54 in women is absolute low limit normal. But that does not mean that this is normal. I mean, you would have to correlate with every other parameters of left ventricle systolic function, maybe global longitudinal strain, maybe MAPSA, maybe mid-wall fractional shortening. Multiple things would have to be seen. Also, you've got to look at the torsion, and also look at circumferential strain. Any of these parameters, many of these parameters could be abnormal in that case. And this may be an early dilated cardiomyopathy. I mean, at least at the beginning of the story. So dilated LV alone would not be there. There would be something else also, unless of course there can be increased preload because and dilated LV because of multiple other reasons, or an athlete, or a mitral regurgitation, or maybe because of anemia, high output state, multiple other reasons. But my point is that whenever you see a dilated LV, I always, and there is no reason for high output state, I always consider disease ventricle. It is a disease ventricle and you have to find out a cause for it. Do not only rely on left ventricle ejection fraction. And if it's more like 52, 53, 54, I would still think there is a beginning of dilated cardiomyopathy.
Correct.
Sir, any features of echo which would suggest a particular secondary etiology that one should specifically look for on echo?
I don't think so. Like Dr. J. Simon has said, that in case you are talking about high cardiac output states and then you see EA ratio, which is more than 2, many a times an anemia, LA is enlarged in all high cardiac output states. You look for the cardiac output, you do a Doppler on the LVOT and see what actually the cardiac output. You might be missing some AV fistula somewhere. I agree with him. Otherwise, there would not be any other specific clues on a dilated heart that what else it could be.
His point was, you have a case which looks like typical dilated cardiomyopathy.
Yes.
Can you guess etiology?
Is that all right?
Yes.
Yeah.
That is that clue that would suggest that it's a particular etiology.
Yes, let's say you are thinking of an amyloid, usually would not produce with a dilated cardiomyopathy of that nature. Thickening would be the first part, but again that cherry on the top. And there are specific parameters which you can use to make an assessment that it is there. Non-compaction is one area where I would really get worried about genetic problems. And then there are kind of some scars in the myocardium. If I look at the anteroseptal segment, and the proximal anteroseptal segment is thinned out, and I might consider sarcoid in that patient. If I have an arrhythmia or an ECG showing some bundle branch block, pattern and an X-ray showing some suggestion of lymph node enlargement, I might think of sarcoidosis, something like that. That's what I could guess. Anything else you would share? Because that I think would be very useful for the audience. Any of us would like to share any clues?
I think, but you are. I mean, you can expand these things further, and maybe somebody has, thyrocardic cardiomyopathy. You know, of course, the features would be there. I mean, somebody has those features of thyrotoxicosis. Somebody has those features of alcoholism outside the heart, tremors, pulmonary edema, things like that. Somebody might have. The hypoparathyroidism, primary hypoparathyroidism. These people tend to get actually calcification of the basal ganglia, also calcification of myocardium. If you see a good amount of calcium myocardium, this is an old septic cardiomyopathy. So many of the, I mean, there are clues, but I think dilated cardiomyopathy is not a diagnosis.
It's not a
It is to begin with.
It's a syndrome.
Now, it's a syndrome. You start looking at everything, and it is a long list of things you have to see. I mean, good. You do genetic studies, one third cases, you will find some clue. Maybe one third cases, if you look carefully on the echocardiogram and also cardiac MRI, you will find a clue, and including an angiogram, you'll find a clue. And one third, of course, are the cases where we'll not find any clue, whatever we keep doing it.
So I think the few treatable causes should not get missed, like pheochromocytoma, tachycardia, cardiomyopathy, easily treatable conditions.
Yeah.
They,
Alcohol.
Alcohol, acromegaly,
Yeah, acromegaly.
thyrotoxic, very B1 deficiency. But we also know that in children, especially hypocalcemic cardiomyopathy, you should not be.
Again, parathyroid and that type.
Yeah, I mean, the vitamin D deficiency and hypocalcemia. We continue to see once a while these cases, and also rarely actually we have seen chronic hypokalemia as a result of hyperaldosteronism leading to dilated cardiomyopathy picture. You just give only aldosterone, you give only the MRA, and these patients recover so quickly. I actually, when I first reported, I thought I may be doing a wonderful job, first person, but then I realized it's not that rare actually. People have described.
I think I would be presenting one case of so-called dilated cardiomyopathy in that 2020 match. Let's hope. So I think if there are no more questions, can we?
Don't forget the hypothyroidism actually. A lot of time, one of the things which is underdiagnosed significantly is hypothyroidism, dilated cardiomyopathy. Is another thing which is reversible actually to a great extent, and we don't pay attention to that.